first presenter will be Dr. Parali Shah. Is she here?
Just wait.
Parali Shah. Okay, Mithun Tulsidas. Second is Dr. Samrat Chatterjee.
So, respected chair and
One. Start
mean,
kar sakte?
Your
4
name
minutes
is
timer is
Mithun.
there, right?
Mithun.
Okay, please can you
Dr.
reset
Mithun,
the timer?
please. Okay.
Okay.
So time is just for info. Time is for 4 minutes only, and 1 minute for discussion, if any. Okay, you can start your presentation.
Yeah, thank you, sir. So, respected chair and delegates, wish you all a very good morning. I'll be talking about phacotrabeculectomy versus small incision cataract surgery trabeculectomy in glaucoma patients. So, as we all know, combining trab with cataract surgery is a common practice to manage coexistent glaucoma with cataracts, as it results in a long-term myopic control and better post-operative visual acuity. However, the technique of phacoemulsification has a few advantages over the traditional manual small incision cataract surgery in terms of incision size, rapid recovery, and lower postoperative astigmatism. Nevertheless, SICS still has a significant role in poor socioeconomic regions where resources and patient affordability are less. So the purpose of the study was to evaluate the outcomes of phacotrab with SICS trab in patients with both cataract and glaucoma. This was a retrospective single surgeon, single center study. These were the inclusion and exclusion criteria. This is how I usually perform an SICS trab. It will be like a single site procedure where I make the triangular flap almost the same size of a sclerocorneal tunnel incision, maybe 5 mm. Then after finishing the SICS, means the cataract part, I'll be making a manual ostium followed by sutures, which in all these cases we have used interrupted sutures. Due to constraints of time, I couldn't show the video. So group 1 included patients with SICS trab and group 2 included patients with phacotrab. In phacotrab, we have done a double site surgery where superior position is used for trab and a temporal clear corneal phaco. The outcome measures included corrected distance visual acuity, intraocular pressure, endothelial cell count, and any complications till 3 months. These are the statistical methods used. 164 eyes of 120 patients were analyzed, and group 1 included 92 eyes and group 2 included 72 eyes. These are the demographic characteristics of the study population. This included open angle closure, and pseudoexfoliative glaucomas. The surgery time was 32 minutes in group 1 and 34 minutes in group 2. However, there was no statistically significant difference between the characteristics. The intraocular pressure reduced significantly in both the groups, and again there was no statistically significant difference between the both. We have also evaluated the success rate based on complete and qualified. Like complete success is defined as something with between IOP 6 and 21 without the use of anti-glaucoma medications or interventions, and qualified success is the same intraocular pressure range with the use of anti-glaucoma medication. So 82% of the eyes, that is 70 eyes out of 92, achieved complete success in group 1, and 66 eyes out of 72 eyes achieved complete success in group 2, that is 83%. The difference in visual acuity between the two groups was also not statistically different. The postoperative complications included hyphema in 2% of the eyes in group 1 and 5% of the eyes in group 2, and there was a tight bleb which we defined as a bleb which failed to form even after a bleb massage. Where we have done a laser suture lysis at 1 week. So it was seen in 2% of the eyes in group 1 and 1.4% in group 2. The major difference came in endothelial cell count, where there was a statistically significant difference between the groups. No eyes developed postoperative hypotony till 3 months follow-up. As we all know, this is not something new. There have been extensive literature done on the same topic. Even a systematic and meta-analysis was done. In terms of intraocular pressure, they found that SICS trab is more favorable than phaco. However, in terms of visual acuity, phaco trab was found to be better than SICS trab in this systematic review. To conclude, in this study, both the techniques were equivalent in providing better IOP control and visual outcomes. And the main purpose of this study is to just highlight the role of SICS trab in poor socioeconomic regions where resources are limited. Thank you.
Okay, thank you.
Yes.
So your definition of success did not have to do anything with percentage IOP reduction from the baseline.
No, ma'am. Actually, that is one limitation where actually we didn't grade the glaucoma to mild, moderate, or we didn't set a target IOP. So it was just defined as between 6 mm and 21 mm. That is one of the limitations of the study.
Yeah.
What was the TREB-induced astigmatism in the phacotreb?
No, sir, actually we didn't analyze the refractive error,
Okay.
but almost depending upon the this thing, like almost all patients achieved a visual acuity of 6/9 or more, because we have excluded cases with very advanced glaucomas like optic atrophy. So we didn't actually analyze the refractive error as such. But the visual acuity, that was like we just analyzed the corrected distance visual acuity, because a post-operative trap-induced astigmatism is expected in both the groups. And even we know phaco will be better definitely when we compare the astigmatism part, when we do compare SICS and trap. So the basic, our thing was to just to control, check the intraocular pressure, and just to highlight the importance in like areas where resources are limited, means it can provide equivalent outcomes.
Okay. You included the patients which having higher astigmatism pre-op?
Oh, no, sir. Nothing was done to roll out the astigmatism part as such.
So we would suggest, when you are doing, this is a retrospective
Yes,
analysis,
sir. Yes,
right?
sir. That is one
So you
limitation.
can go into the records and classify the cataracts, classify
Exactly,
the
caption
glaucoma, and
glaucoma
then
part.
do a sub-analysis
Yes, ma'am. Yes, ma'am.
for further presentation.
Yes, ma'am. Even we can set a target IOP and
Yeah,
check it
and then
accordingly.
check how many were like
Yes,
less than 20% reduction, more than 20% reduction from the baseline.
Definitely.
Right?
Thank you.
Thank you.
Thank you.
Next is Dr. Samrat Chatterjee.
No, he has not changed the presentation. And the timer disappeared off from there after 2 minutes. So can you please instruct them that it should not disappear off so that we know that? This is not mine. This is the one, I think,
Hello.
Dr. Samrat Chatterjee.
So AV team when
Third,
The third one.
Third one. Samrat Chatterjee. Third, yeah.
Good morning. During July of 2023, an epidemic of viral conjunctivitis swept across the country, even in our state. So the aim of this report is to present the attack or the incident rates, to get an insight into the transmission dynamics of the outbreak and risk factors, cost of treatment and wages, to understand the economic impact of it on the society and health-seeking behavior of the patients. So we conducted a cross-sectional survey in September 2023, a few weeks after the outbreak had lessened. After sample size calculation, we selected patients from Raipur district using a two-tiered random sampling and systematic sampling strategy. So 214 households were approached, and of which 196 participated. 88 households had 309 patients with conjunctivitis. So the primary attack rate, or the incidence rate of the outbreak overall was 32.5, in rural areas was 49, and in the city it was 25.4. It was significantly higher than two previous studies, and the incidence rate or the attack rate in the rural areas was comparable to two studies of acute hemorrhagic conjunctivitis. There was the median probability that the infection would spread from the index case to other household members was 100%. And 64.8% of all household members other than the index cases were affected in the outbreak. And there were around 54.5 households where all members were affected by the outbreak. Only one other study has analyzed the secondary attack rates that gives the transmission dynamics within a household. Our figures are significantly higher than that. The risk groups were patients living in villages, those who were less than 20 years of age, and those who were working. Most of the patients sought treatment from the pharmacy without a prescription. Around 21% sought treatment from the ophthalmologist. We analyzed what factors influence the treatment choices of patients. So we did a multinomial logistic regression where we compared the different treatment choices with the treatment choice of no treatment or home remedies. We found that households which had the highest female education, graduate level or above preferred home remedies or no treatment over ophthalmologist or over pharmacy. Widows or separated or living alone, they preferred home remedies and no treatment over quacks. People in rural areas preferred no treatment over pharmacy, and only the middle and upper socioeconomic category patients preferred pharmacy over home remedies. There was no trend for ophthalmologists. Majority of the patients used prophylaxis. The most common prophylaxis was wearing goggles or frequent hand washing, and we found that the risk rate of outbreak spreading into the family was much less if the index patient had used some form of prophylaxis. We extrapolated the findings of our data into the Raipur population, and we found that around 121 crores of rupees was spent on treatment, and the productivity loss from absenteeism from work was around 76 crores. So to conclude, the outbreak was highly infectious. The vulnerable age groups were people who were living in villages and children. So future public health intervention should address these risk groups. They should also address risk groups where you prevent pharmacies from directly selling medications off the counter, and promote prophylactic measures to prevent the outbreak from spreading within the family. Thank you.
Thank you, sir.
So, anything you have seen, how much time he has taken to regress the viral conjunctivitis? How much time?
See, this was a cross-sectional study that we did not study the clinical factor period. But in the because this was a survey in the community, but during that survey we also did some hospital-based studies. Now, hospital-based studies do not give you the actual transmission dynamics or risk groups, because we know, you saw, no, only 21% saw treatment from ophthalmologists. Very few saw treatment from government institutes. So it doesn't give us the community or the epidemiological perspective. But in the clinics, because you asked, in clinics, the conjunctivitis that we studied, the median was around 2 to 4 days. That was our experience in our part of the country.
So this one is basically very short phase viral conjunctivitis.
Very short phase, most probably, we think it's enterovirus, and we have isolated enterovirus in our area.
So the diagnosis of conjunctivitis was made only on torchlight examination, or?
No, this was, see, it's a typical this thing. The case definition was if you had redness, watering, and symptoms of discomfort with or without pain, and if the other members were affected. So in previous outbreaks also, where you do these kind of studies, they take this kind of a reportage. So there may be a small percentage of patients in this where it could be some other cause, but given the pattern within the household, it is unlikely that all these patients did not have viral conjunctivitis, but had got something else. But it was based on the patient-reported symptoms. That's how these kind of studies are conducted in epidemiology.
Did you have a questionnaire, sir?
Yeah, we had a Google-based form, a questionnaire, which was implemented by trained optometrists, and that's how we got the data.
I think we should include it in the methodology.
It's there in the methodology.
Okay.
Because it's just 4 minutes, right?
Yeah,
So we cannot give if you want to see, it's there.
Okay.
So I just highlighted the sampling and all. There's a Google-based form is there.
Okay. Thank you, sir.
Thank you.
So next presentation, Dr. Pragya Ahuja, available? Yeah. So she will be presenting on donor profile, mode of collection, and tissue profile of voluntary versus HCRP corneal donation.
Good morning, respected judges and fellow colleagues. I'll be presenting donor profile, mode of collection, and tissue profile of voluntary versus HCRP corneal donation, a 6-year analysis. On 25th March, lockdown was declared, wherein donor organ procurement and screening, as well as general reorganization of health services, had a profound impact on the delivery of organs. India generally follows an opt-in system of eye donation, wherein individuals or the next of kin generally manifest their preference for donation. Eye donation can be voluntary or hospital-based, wherein in hospital-based, a trained professional grief counselor motivates the family of the deceased for donation in hospital setting. Available medical history, access to younger tissues, and less death to retrieval time and cost effectiveness has been conventionally declared as advantages of HCRP. Ours was a retrospective research study. Donor corneas received in the eye bank over 6 financial years from March 2017 to 23 were analyzed. Donations received before lockdown, that is from 2017 to 20, were categorized in the pre-COVID category, and those from 20 to 23 were in the post-COVID category. Total of 7,741 corneas collected over 6 years were included in the study. 53.4% of these donations were from males and 46% were from females. No significant correlation was seen between the gender and voluntary donations over these years. 30.5% donations of donors were patients of less than 50 years, less than 50 years were voluntary donations, and more than 50 years, only 52.4% donations were voluntary. There was no significant correlation between the age and the voluntary donations received. We saw a trend of donations over the years, wherein during the COVID era, HCRP donations decreased, while the voluntary donations did not see a significant decline over the years. However, instead, post-COVID, the voluntary donations have increased in overall. The number of optical tissues collected over the years from voluntary donations we saw an increasing trend. While in HCRP it was 766 in the last, HCRP it was 453 in the last year, while it was 527 in voluntary donations. Tissue grading: most of the tissues received by voluntary donations were from fair to very good, and those received from HCRP were those received from HCRP were of good category. 68% of tissues from voluntary sources in the COVID era were in the COVID era, while 44% of the good tissues were of good category in the pre-COVID era. Those in the HCRP group, and 60% in the COVID group. The utilization of tissue for optical purposes increased significantly in the voluntary donation, 26.3% in the pre-COVID versus 35% in the COVID group, but no such significant increase was seen in the HCRP group. The tissue utilization between the two groups was significant, with the tissue 84.6% utilization in the voluntary group and up to 84.3% in the HCRP group. The comparison between these pre and post-COVID independently in the voluntary and HCRP categories was significant. Public awareness programs are active for the last few decades with financial support from various NGOs, which has helped improve the percentage of voluntary eye donations. The major disadvantage of these is that the next of kin needs to realize the responsibility of eye donation, and the motivation is a drawback, which helps in because of which most of the studies reported from other parts like Nepal Eye Bank and Delhi have seen only very few voluntary donations from 12 to 20%. Increase in optical tissues is compared from voluntary was comparable to HCRP in our study. We emphasize more focus on IEC studies with the need of removal of stigma around eye donation. Thank you.
Thank you, Dr. Pragya.
Thank you.
Next time, make your slides little less crowded so that you can give more information in lesser time. Okay.
Next is Dr. Rajivan Samuel Ponras.
Good morning to one and all, and I want to thank AIOS for having given me this opportunity. So this study is about a DigiRope calculator, in order to validate this calculator, which has already been done in developed countries. So it is an online individualized predicted system of a 95% confidence interval. It is a sight-threatening ROP in order to determine the sight-threatening ROP requiring treatment. So it is it was actually incorporated and done by the Swedish group in the Sahlgrenska Center. And a study has already been done previously by Purdock et al. And he used the risk factors, namely gestational age, the birth weight, and the gender, male, female. So it's an online accessible calculator. Anybody can access it online. 513 premature infants were prospectively examined. It is a study period between June 2020 and May 2022. The inclusion criteria is inclusive of
premature infants born between 24 to 30 weeks of gestation, and birth characteristics of gestation age, birth weight, and gender. Exclusion criteria have excluded all the missing and incomplete data, and like other high risk factors and congenital anomalies and other eye diseases apart from ROP. The study sample is out of 513 infants. 164 were selected for the study based on inclusion criteria, and the gender distribution was 74 is to 90 girls. So this DigiRope birth calculator incorporates gestational age, birth weight, and gender. So these these are the tables which show the birth weight, the gestational age. Sorry for the clarity is not very good. Yeah. So the standard deviation is 2641 here, and it's 1.83 over here for gestation age. 84 were among the ROP babies, the premature babies who didn't need treatment, and needed treatment were 80. The ROC curve is the predictive ability with it had a lesser satisfactory result of an area under curve of 0.718 in comparison to previously reported. So previous reported studies show that the percentage was at least above an average of 90%, but this study doesn't reach to that standard. It is coming to around 0.718. The sensitivity of the study was 90%. The specificity was 53.6% in comparison with Pivadak and et al. Study in Sweden of 96% and 50% respectively. The results here, it is unusually the males were shown to have a higher prediction for ROP treatment in the future compared to males for the reasons of because of hormonal imbalances and also because of certain pro-inflammatory cytokines factors. The sensitivity is 90% and the specificity was 53.6%. Here again, this table actually denotes will depict where the males actually they have a higher prediction of needing ROP treatment in the future. The discussion, the global impact. ROP is a leading cause of childhood blindness globally. The risk factors are predominantly are low birth weight and smaller gestational age. So the birth weight, the DigiRope birth model is an easy to use validated calculator and aids in identifying the high risk premature infants who need increased eye examination. So the study insights is that the area under curve is 0.718% and nearly 48.7% of selected babies needed to show treatment. The gender influence, the males predominated in the study. So in conclusion, the treatment related ROP sensitivity and the area under curve prediction were less satisfactory in comparison with the other studies done in developed countries. The model validated for ROP babies with younger gestational ages included those up to 24 weeks and extremely low birth weight infants. This study also confirms that the male genders had a higher significant risk factor in influencing the treatment related requiring ROP predictions. This study also emphasizes the need for even the postnatal risk factors, which could also enhance the treatment requiring ROP efficacy, and this suggests potential modifications to the DigiRope bird model in the future. Thank you. Thank you, madam.
Thank you, Dr. Rajvin. So there are now artificial intelligence used for ROP screening.
Yes, madam.
So DigiROP is only taking into consideration 3 characteristics of
Exactly,
the baby,
yes,
right?
madam. Yes, madam.
So do you feel you can use it on a larger basis?
There is actually another modified version of the DigiRope, but because this study I only could get the parameters of birth weight and gestational age in the study for among the 164 babies, so I was able to confine to the DigiRope bird model. There is another type of DigiRope model actually, I forget the name actually. It is a modified version, but that even included other postnatal factors.
Yeah.
Like the neonatal jaundice and other additional factors at postnatal. So those things had to be incorporated. Since I didn't have those risk factors, I could only confine to the DigiRope bird model. There are ongoing researches like this in the future. So this study actually inspired me, and I thought I have to bring it here to
because we need to have a good sensitivity.
Yes, exactly. Probably my study sample was a little less actually. Probably if I had taken a long period, probably I could validate it a little better.
Okay,
thank you so much.
Next presenter is Dr. Hari Badrianan.
A very good morning to one and all. My name is Dr. Hari Badri Anand, and these are my co-authors. Today I'll be talking about greening eye care, the environmental sustainability of outreach and telemedicine at our tertiary care center. So looking at vision centers, they are set up in semi-urban or rural population areas with a population of 50 to 60,000 and 100 kilometers from our tertiary care center, which is called a base hospital. They are a facility around 600 square feet in size with 2 trained staff seeing around 50 patients per day. And we perform all basic procedures that are done at an ophthalmic hospital, including registration, BP recording, and looking at the vitals of the patient. Fundus photography, performing offline AI analysis on the same, syncing with the EMR system, refractive assessment of the patient followed by a slit lamp exam, applanation tonometry as required, dilation, fundus evaluation, and then consultation with the doctor through a telemedicine platform, and followed by a glass prescription or medicine or drug prescription as per the doctor's discretion. So looking at our center, which has 17 vision centers under it as of 2023, we analyze the numbers that we've seen over the years. In 2007, we had a very measly uptake of around 10,000 patients per year, but come 2022, we are seeing over 160,000 patients per year, averaging more than 50 per day at each center, with just a COVID drop seen in 2020. Now looking at 2022, we've seen north of 170,000 patients at the VC, with only 15,000 odd patients needing referral, which is just 9% of the patients that we've attended to, and 14,000 pairs of glasses being ordered and accepted at the center itself. The main takeaway point is that 90% of them completed their care at the vision center without need for further referral or travel, which cut down the travel requirements to the hospital. Now we wanted to quantify whatever carbon emission reduction that we've achieved through transport emissions reduced in this program. We came upon a very interesting paper under the India GSG program termed the WRI, which gave us very specific transport emission factors for vehicular norms that are set in India. Now we had a retrospective analysis of our 2022 data wherein we looked at the cumulative distance reduced due to intervention at the vision center level. And I'd like to draw your attention to this point. We achieved close to a reduction of 1 crore kilometers covered for all the patients involved. Now looking at this cumulative visit total, nearly 90% of the patients who were treated at the vision centers itself worked around 20.6 million kilometers of travel reduced, which equaled 3,000 tons of carbon dioxide emissions saved and 130,000 trees planted. Looking at the COVID model, we had a very interesting work that came out during that point of time, which got published in the WHO bulletin, which said that even during the first wave and the second wave, the primary centers, which is the vision centers, had a good uptake of patients. That is near 70% to 80% of the normal caseload could access the vision centers and avail healthcare at their point of choice. So we wanted to leverage the same and reduce carbon dioxide emissions across the spectrum during our COVID crisis, wherein we came up with 2 models. This is the same-day surgery model, reducing the need to a single base hospital visit, wherein just the operative visit would be taken care of at the base hospital and pre- and post-operative would be handled at the VC. And the post-operative visits, wherein ease of travel would be increased and there would be lesser patients who are lost to follow-up, wherein only the post-operative visit would be taken care of at the VC. Now looking at the carbon dioxide emissions that we have reduced during the same, looking at the same-day surgery model, we've reduced around 48 tons in 2022 alone. And looking at the post-operative day visits, nearly 27% of our total cataract surgery load are addressed off at the vision centers as of today, and we've reduced around 300 tons of carbon dioxide emissions on the same. Now looking at the uptake across the years, in 2019 when it was first introduced, nearly 20% were only 20% were uptaking the same, but come 2022 we've seen north of 60% patients choose for a post-operative day 1 visit at the vision center. Looking at the cumulative effect, we've saved north of 3,000 tons in carbon dioxide emissions and 150,000 trees planted, and this is just from one single tertiary care center hospital. And I would like to draw your attention to the fact that if it were larger, if it were across the spectrum, we would have a much wider impact on healthcare as a whole.
Very nicely done presentation.
Thank you, sir.
So this one is fund examination done by?
Sorry, sir. Could you
Fundus examination done?
Yes, sir. The fundus examination is done by an MLOP. It's a mid-level ophthalmic personnel. She's a trained personnel who's trained to capture the images and is given basic ophthalmic
Captured
training.
by?
It's captured by, right now we are affiliated with Remedio. So we are using the
Remedio.
Remedio non-mydriatic fundus
Non-mydriatic
photography.
fundus
Yes, sir. Followed by offline AI analysis, which is shown to the doctor who's at the tertiary care center.
Offline?
Yes, sir. The thing is that connectivity is always an issue.
Okay.
So the AI analysis is performed on the phone offline.
Okay.
Thank you.
Thank you. Next speaker is Dr. Kavita Rajan Bhatnagar.
A very good morning to all. Thank you, AIOC, for giving me this opportunity. I have no conflict of interest. So the topic is a study of patient outcome with tele and physical consultation during and after the COVID-19 pandemic. These are my co-authors. So COVID-19 pandemic posed significant challenges to an already overburdened healthcare system in our country, and telemedicine came as a rescue, a cost-effective rescue measure amid all physical restrictions. We have few, programs already running in our country successfully. So the objective of our study was to assess patients' outcome as well as satisfaction with the eye care they had received with both telemedicine and physical consultation at a tertiary care academic institution during and after the COVID-19 pandemic. It was an ambispecative descriptive study. Outcome scoring was developed by us and validated by our department. The sample size for physical consultation group was 2,485. For telemedicine group, it was 3,567. PSQ 18 questionnaire was used for patient satisfaction for physical consultation, and TUQ, telehealth usability questionnaire, was used for telemedicine group satisfaction. This is the outcome scoring system. These are the TUQ and PSQ questionnaire. Due to paucity of time, I'm not going to read out the questionnaire. So a significance was seen in scores for pain and redness in all diseases pre and post treatment, as you can see from the table for retrospective physical consultation group. Same was seen for prospective physical consultation group. As you can see, the p-values are significant across all disease spectrum. Significance was seen in scores for pain and redness for all diseases pre and post treatment for telemedicine group, as well as can be seen from the tables. The p-values are statistically significant for all the diseases. This table shows telemedicine consultation patients' TUQ scores compared with individual symptoms. Patients were highly satisfied. Even significance was seen in scores for all subclasses of questionnaire in retrospective and physical consultation groups using PSQ 18 questionnaire, as can be seen from the table. So there was a significant reduction in pain and redness in both physical and telemedicine consultation groups that proved that telemedicine to be an equally effective alternative in times of crisis, whether natural calamity or things like COVID-19 pandemic. We all faced a lot of problems managing these patients. Though 83.71% patients had to be subsequently converted into the physical consultation group due to diseases like refractive errors, glaucoma, retinal diseases who needed laser treatment or OCT or FFAs, and corneal ulcers and emergency cases who needed surgery. Still, high levels of satisfactions were found using TUQ, except for reliability in telemedicine group, where patients were highly satisfied in physical consultation group across all dimensions of PSQ 18. The limitations of study were that it's a single center assessment, so it can't, the results can't be generalized to the general population, and we could not assess the cost effectiveness of telemedicine per se, except for their satisfaction in the form of questionnaire. Okay, thank you. So just to conclude that yes, telemedicine will always, come to our rescue in times of crisis and can always, be a helpful measure. Thank you.
Thank you, ma'am. We totally agree that telemedicine actually has come to help more so after COVID-19
Yes.
pandemic.
Yes.
Thank you, ma'am.
Thank you.
Next speaker is Dr. Rashmita Ravishankar.
A very good morning to the dignitaries and my colleagues and friends. I'm going to be presenting the learnings from a 17-year-old eye bank from a tertiary eye care center in South India. Our eye bank was inaugurated in the year 2006 with support from the National Rural Health Mission and an active involvement from the government. So the very first lesson we learned here was that involvement of the government has ensured efficient functioning and growth of our eye bank. Looking at the trend of our eye bank over the years, we started with a meager collection, and then with the initiation of HCRP in the year 2010, our collections really skyrocketed, and this trend continued up until the year 2020 when we were hit with the COVID-19 lockdown, but we have since then showed a good recovery. So the initiation of the HCRP helped to tremendously increase the collection single-handedly. And every year during the National Eye Donation Fortnight, we hold awareness exhibitions and pledging stations. We also organize awareness rallies and innovative methods like flash mobs at public places like the malls with a dedicated pledging station. And every year we hold donor meets to encourage, motivate, and felicitate the family of the volunteers and the donors. And we have a very active social media presence where we hope to motivate and validate the contributions of our counselors and volunteers every month. And we've learned that the continuous and innovative ways of community engagement and motivation to be catalysts in this process of eliminating blindness has helped increase the efficiency of our eye bank. We are continually engaged in research, and to use it to our advantage, we've learned that NGOs play a vital role in encouraging voluntary eye donations, which are important as well. And a targeted education and motivation of the younger population is needed to increase voluntary donations. We also conducted a study to assess the knowledge, attitude, and practice among ambulance drivers and freezer box workers towards eye donation. And on analyzing our results and using it to our advantage, we arranged an awareness session among these community grief counselors to enhance voluntary eye donations. So drawing from the role of NGOs, we came up with the concept of community grief counselors, where non-medical workers from the community could help in motivating voluntary eye donations. But our greatest strength perhaps lies in identifying our biggest weaknesses. And despite a healthy collection rate, our utilization rates have stayed at around 30% of our collections. And we identified and analyzed the reasons for non-utilization and tackled them one by one. And by introducing the in-situ procurement method, we were able to deal with the issue of collapsed globes and damaged corneas, and this has also significantly decreased our processing time. And if on rare occasions we are unable to collect a blood sample, or if the cause of death is a contraindication, the whole globe is enucleated. And in this way, we have tackled two issues at once, and also saved the storage media wastage, prevented storage media wastage, and increased the tissue eyeballs available for surgical training. We also are involved in targeted training of our doctors to ensure optimal tissue utilization. And during the COVID-19 crisis, the cornea collections, as you all know, hit an all-time low. And then we started preserving these corneas in glycerine, and thereby we were able to use these for emergency therapeutic and tectonic purposes by increasing their shelf life. We are also involved in brainstorming sessions, and we are working at an infrared-based vein finder and a portable centrifuge with hopes to eliminate the conundrum of lysed blood samples. To consolidate, these are our findings and of our results, and we hope to use these ourselves and propagate it to other eye banks, especially government involvement, HCRP to boost collections, actively involving in research and modifying eye bank strategies to help increase the efficiency. And perhaps the biggest learning we've had is from the crisis of COVID-19 that has helped us increase our utilization as well. And soon we hope to see more dark blue hues on this map of India. Thank you.
Thank you, nicely done. So anything extra you have done for the corneal donation, to increase the corneal donation in your center?
So particularly in our center, whenever a patient comes with a corneal blindness, we have a dedicated counselor who talks to the patient as well as the counselor, and sort of I think they are more sensitive to this issue of corneal blindness, and they are the targets we have to motivate, and we even encourage the attender of the patients to pledge their eyes and inform that just pledging the eyes is not enough. Your family has to give consent for your cornea to be retrieved. So to propagate this message in the community through the patients who come to us.
So probably, our center, we have started the WhatsApp. Anybody was come, we have got short video of WhatsApp for 20 seconds and followed by question and answer, whether you want to do the corneal donation or not, followed by second visit for pledging.
We have these little activities planned during the eye donation fortnight as well. Yes, it would be better if we could continually do it throughout the year and rather than just a particular fortnight.
Thank you, Dr. Rashmita. The next speaker is Dr. Naren Shetty.
Morning, everyone. I'd like to thank AIOS for giving me this opportunity. These are my financial disclosures. Now, if you look at the number of cells in our body and look at the amount of bacteria in our body, actually there's more bacteria than actually the cells. And most of it is found in the GI's tract. And it's not just the bacteria. Actually, we have in the normal flora, we have bacteria, we have fungal, we have virus. And each organism keep a check between each other so that there's a perfect balance between all the organisms. And when there's a perfect balance, there's a very good, that makes the whole body, it has a lot of benefits and makes the body extremely, extremely healthy. But when there's a break in balance by consuming either antibiotics, antifungal, or so on and so forth, it leads to a lot of side effects and you're prone for infection, the immunity is really down, and so on and so forth. Now, in the community, there's an increased consumption of probiotics, and the research question is, what happens to the ocular surface when you consume probiotics alone as compared to combining probiotics and probiotic fungus? So this was a prospective study where we looked at 48 eyes of 24 patients. A detailed ocular and systemic examination was done. We picked only healthy individuals who did not have any abnormality in the eyes or in the system. And what we did was we grouped these patients into two. Group 1 were the patients who were consuming both probiotics and probiotic fungus, and Group 2 consumed only probiotic. And the tears were collected before the starting of the study, and then it was collected at 1 month and 3 months after the start of the study. All the tests were done. The biomarker test was done using the BioPath Finder. Basically, it is an antigen antibody reaction. And when you look at the results, we found something very interesting. In patients who consumed both probiotics and probiotic fungus, had lower levels of inflammatory markers. Basically, there was lower levels of MMP9, IL-1 beta, IL-6, and there was beneficially higher levels of IL-10. And when you look at the other group who consumed only probiotics, there was higher level of inflammatory markers with IL-1 beta, TNF-alpha, and IL-17A were at the higher level. So basically, by consuming both probiotics and probiotic fungus, there was beneficiary effect where it lowered the inflammation. And when you consume only probiotics, it increases the inflammation. And we really feel this increases mainly because it's when you consume only probiotics, we feel that it's creating an imbalance between the flora, and that is why it's creating more inflammation. So what was known was human ocular surface does get affected by external and internal factors. Tear biomarkers have been happening in the last couple of years. What this study adds is consuming a probiotic significantly affects the ocular surface, and consuming probiotics and probiotic fungus has beneficial effect. It reduces the inflammation, and consuming probiotics only increases the inflammation. And this has never been shown before, and is a very interesting finding what we found. Thank you so much for your time.
Thank you. Very nice. What was the cost of that kit?
So the diagnostic kit, it's about the device itself is about 10 lakhs, but the cartridges is around we're looking at 10,000 or so, ma'am. Yeah, 5 to 10,000
per patient.
No. In the same cassette, we can analyze about 8 patients.
Okay.
Thank you so much.
Yeah, thank you.
Do you recommend probiotics for corneal?
Sorry, sir.
Do you recommend for probiotics and fungal?
So it is so what we used for the study was Saccharomyces boulardii. That works really well because a lot of times most of the probiotics in the market is just a plain pre and probiotic of the bacterial kind. There is no fungal combination. It's very rare actually. There's a fungus, but what we feel is when you give more, it's basically trying to give more food or letting the bacteria go flourish much more than the fungus, and then it's creating this imbalance. And because it's creating imbalance, it's increasing the inflammation, because the balance is extremely crucial for keeping the body very healthy.
In what kind of patients are you, giving this probiotics plus fungus?
So to have a very controlled study, actually we analyzed the community as a general, but we found that a lot of people don't follow the tablets very properly and this. So we try to have a very controlled study where we made sure the patient, the people ate the tablets in front of one individual so that it's fully controlled.
So we presume that you had a baseline
Yes, before they started.
starting.
Absolutely,
and
ma'am.
then, at 1 month and 3 months
Yes, ma'am.
after
Yes,
starting.
ma'am. Yes, ma'am. So then we could see the change, and when they took the combination, the inflammation, ocular inflammation reduced, and when they took only probiotics, inflammation increased. And this is, has never been documented in the ocular surface before, ma'am.
And did you do any symptomatic evaluation from the patient side or by a questionnaire? How
We
were
did.
they feeling?
Actually, clinically, it didn't show, ma'am, because 1 month and 3 months can be a very short time because of these kind of inflammatory markers. We have to see, maybe it leads to, these chronic dry eyes and other things. But clinically, when we tested it at 1 month and 3 months, we didn't find any clinical evidence. But only thing what we saw is subclinical inflammation. And a lot of patients, like cataract patients, when we see, we have screened preoperatively a lot of cataract patients. A lot of patients where you see in the slit lamp perfectly normal, and we looked at the tears, significant, almost 40% of our cataract patients had subclinical inflammation. And these are the patients, when we do the surgery, after the surgery, they keep complaining of dry eyes and this. So because we are doing double insult, there is some amount of subclinical inflammation, and then we're doing the surgery, which again induces inflammation. Then it goes over the threshold, and then it leads to a long-term problems.
Okay, thank you.
Thank you, ma'am. Thank you, sir.
Next is Pradhan.
Good morning. Today I'll be presenting the visual profile of children with special needs who visited an early intervention and rehabilitation center. I have no financial interest. So an estimated 1.3 billion people in the world, they experience some significant disability, and in India this number crosses 2.68 crores, with the highest percentage of patients falling in the age group of 10 to 19 years. So in order to empower these patients and to have an early intervention as early as possible between the age group of 0 to 6 years, the Government of India has come up with the concept of early intervention and rehabilitation center. So these has all these multiple different departments which cater to the needs of these children. So the one that I'm talking about started in July 2023 under the Topiwala National Medical College in Mumbai. We have seen over 1,500 patients till date, and in ophthalmology department there were around 420 patients. So the methodology included history-taking, vision evaluation, cycloplegic refraction, anterior-posterior segment evaluation, and cognitive vision assessment. These are what we use to assess the vision in special children. A little about cognitive vision evaluation. It is essentially how the brain perceives the vision, which has a lot of components including color vision, contrast sensitivity, stereopsis, directionality, Saccard's pursuits, etc., etc. So the results of the first 400 patients included showed us that 2/3 were males, and as we know, it is already targeting 0 to 6 years of age, but we had a significant set of patients coming in the age group of 7 to 10 years. Majority were referred to us by other departments, and around 80 patients were referred to us by their school teachers. 40% patient had global developmental delay, with cerebral palsy being the most common cause, along with some behavioral abnormalities like autism and ADHD. Ocular ailments were seen in 90% patients, with refractive error being the most common problem, followed by strabismus. And amongst the refractive error, astigmatism was the highest CADR, and strabismus was of variable angle, with exotropia being more common than esotropia. The management included spectacles, vision therapies, low vision aids, and only 25 patients underwent squint correction surgery. So coming to the discussion, cerebral visual impairment, it covers a wide range of problem, which includes visual perceptual impairments resulting from dysfunction or injury to the retrogenicular pathway. This is the single most common cause of vision impairment in young children, and the most common cause of CVI is hypoxic ischemic injury, which because of which it's very important to ask for perinatal history, perinatal insult, history of neonatal seizures or seizures in the first 6 months of life. 61% of the patients who visited our clinic had a history of perinatal insult. Now coming to autism and vision impairment, they have a vicious role against each other. We already know that vision impairment, patients who have severe vision impairment, many of them develop aggressive autistic-like traits. But in the recent years, we have seen that patients with autism have also been found to have some amount of vision impairment. So if we treat those, their behavior has been shown to improve the moment their ocular ailments are addressed. So 53% of autistic patients who attended our Ophthal OPD were found to have refractive error. So to conclude, I want to emphasize on the fact that it is very important to identify the systemic ailment as early as possible. And as an ophthalmologist, we have to try glasses first. And we have to give basic vision stimulation exercises which will help the babies in the long run. It is very imperative to know that there are such dedicated institutions available across the country which have this multidisciplinary approach, and a regular long-term follow-up will help all of them. Thank you.
Thank you, Dr. Priyarthi. Nice concept.
Yes, ma'am.
Thank you.
Thank you.
The next speaker is Dr. Devjit.
Good morning, everyone. My study is on epidemiological characteristics of fungal keratitis. These are my co-author. Our aim was to study the epidemiological characteristics of fungal keratitis seen at a tertiary health center in Barak Valley of Assam, that is at southern Assam. It was a retrospective analytic study for a period of 2 years from September 2021 to August 2023. We have taken culture proven fungal keratitis cases, confirmed it were about 103 cases out of 299 corneal ulcers, and detailed history and slit lamp examination was done. Size of the epithelial defect and stromal infiltrations was recorded. Sketch was drawn on a designated document, and hypopyon was measured. Its presence as absence was noted. Then scrapings were sent for gram stain, KOS mount, and culture and sensitivity test. And out of 299 patients, 103 cases were found to be fungal etiology, 101 were of bacterial etiology, and 14% were of mixed bacterial and fungal growth. The remaining 81 patients were culture negative. Among the fungal keratitis, male were 67, that was 65.05%, and 66.99% were of younger age group, that is 21 to 50 years of age group. 83 patients were from rural areas. Out of 83, 67 were pharma. And ocular trauma was found in 95 patients, and out of which 63 patients had vegetative injury. 16% had concurrent diabetes mellitus, and the incidence was higher between the month of June and September. We can see here that the male patients were predominating, 65.08% was there, and female was 34.98%. The age group, almost 66% were in the age group of 21 to 50 years, and among them, in the age group of 41 to 50 years, it was 29% almost. And coming to the occupational history, agricultural worker was the main target. Was agricultural worker was the main target. There was 66.05% patient were from agricultural field, and 18% were from the laborer field. Coming to the predisposing factor, corneal trauma was found in 95% out of 103 patients, and coexisting ocular disease were there: viral keratitis, dacryocystitis, lead abnormalities, adherent glaucoma. They were of minimal incidence. We could not find any case of leg ophthalmos. And coming to the traumatic agent, vegetative matter was the culprit for 61.16% of patients. And next being the insect bite, it was 6.8%, and dust particles were in 4.85% of patients. So from our study, we got that 34.4% of all corneal ulcer patients were of fungal origin in that locality, and 4.7% were of mixed fungal and bacterial origin. Male predominance of the younger age group, 80.58% were from rural areas, and 65 of them were are pharma, and 92.23% had ocular trauma, out of which 61.16% had history of vegetative injury. 15.5% had concurrent diabetes mellitus, and incidence was higher in the month of June through September. A similar report, earlier study also given the similar report, like 7.3% in North India of incidence of fungal keratitis, and 32% in East India, 38.9% in West India, and 32 to 39.8% in South India.
Thank you. So, what's new in your study?
The trend is same, but it was necessary to do a study in that locality as there was no any previous study at that locality. But trend is same.
Yes, something said about snake bite.
No, insect bite.
Insect bite.
Yes, not snake bite.
Thank you. The next speaker is Dr. Pooja Hingorani.
I'll also need the pointer.
AV team.
Pointer is there.
Yeah. So, good morning, everyone. This was very interesting. We noted certain things that we were designated as the NEET PWD or Patients with Disabilities Verification Center. To begin with, patients with disabilities, not just physical and intellectual as we think, but also mental and sensory. And anything above 40% is a benchmark disability when it comes to classifying NEET students as a PWD criteria. So when students are about to give the NEET exam, they are supposed to register as PWD by a certificate, disability certificate given at the district level. But after giving the exam and getting the result, they are supposed to verify that disability with 16 centers, out of which one is ours, all over India. So what we noticed was, so this is the way we classify. Two things in this which I want you to see is, anything 30% is one-eyed, and it is under the PWD criteria. It does not satisfy the PWD criteria. The category 3, 40 to 80% is PWD criteria. Above 80% is blindness. So again, it's not visual impairment. So students cannot apply for MBBS. So based on this, we wanted to see how much was the difference in disability percentages from the primary center to the tertiary center. That means the first certificate to the second certificate. And the ratio of students who applied to us, how many of them were really eligible to apply for MBBS. The secondary was how many of these students were malingering and what was the reasons for this. So it was a retrospective hospital record-based study. We were a center since 4 years, and the NEET students were the ones included, consecutive sampling amounting to 154 students. So the only ones we excluded were the ones with multiple disabilities, because there's a separate formula for those. So this was again we classified the data, and guess what? This is our result. The average rank, open rank, is 5.22 lakhs, which comes down to 1,300, a dramatic 400 times change in an asking percentage. So this is the reason. Now what we saw that among, just one sec. So 98% of the students would have been eligible had it been only through the primary center, but actually they were only 29% from our center. These were the students who were eligible above 40%, less than 80%. And amongst those who were classified as less than 40% by the primary center, we almost agreed with all. But amongst those who had 40%, we disagreed with 91%. They were less than what were given by the primary center. Amongst them, 0% was in 27%, and 30%, that means one-eyed, was in 44%. Similarly, to those who were given more than 40% by the primary center, we disagreed with a huge amount, out of which again 0% was, and 30% were significant. So this was the agreement statistics. On an average, our percentage was 24% less than the center. The mode was 0%. Most of the students had 0% disability out of the 154. Median was 30%. So we realized that the students having 0% disability were the ones we classified as malingering, with 30% of the total. And 75% had some sort of exaggeration. They had 10% disability but came as 40, or they had 20 and came as 40, etc. So why is this happening in primary centers? Maybe lack of index of suspicion, lack of sophisticated equipment to rule out malingering, non-availability of visual field testing at their centers, inadequate, the last two slides. Inadequate training, or is it sympathetic attitude towards the local students? And why is this trend? Because this stress on bacha doctor banega, a difference in asking percentage, and this is 4 days ago, Times of India has reported 20 lakh students have applied for NEET this year versus 3 lakhs, 0.7 lakhs in 2015. So we would suggest this triangle or base approach. We repeat vision, we randomize, we counsel the students. Second level, we do visual fields, and third level, we do VEPs also. So one thing we have to be very watchful against is the diagnosis of amblyopia. So in conclusion, 18% only showed agreement, 29% only of the students were actually eligible. Out of these, many were one-eyed, and 30% had no disability at all. Among the 70% with some disability, most of them had an exaggerated score. Of these, 94% were not eligible. So the role of an ophthalmologist, primary center training, beware of the diagnosis of amblyopia, using HFA, suspicion of one-eyed patients, and this is something that we have faced. We have been threatened by relatives, and so what we follow is parents outside, guard inside, and students counseling. Thank you so much.
Wow, very nice, ma'am. This is one of its kind of a study.
This has never been done, and this is actually the social situation of India right now.
But why do the students malinger?
Ma'am, 400 change in rank from 5 lakhs to 1300. So they literally fight with us, and they come and they fight and they say, oh, you're spoiling my child's 1 year or 2 years of study. You have to consider this. And we've had, relatives, in the goons in the form of relatives, ye mama hai, ye chacha hai, come into our clinics and actually tell us, oh, you're spoiling my child. Some children even threaten us that we'll commit suicide. And these are MBBS students, and it's a very difficult thing, and nothing has been done about.
Actually, it is a huge issue, but you have rightly pointed out, primary health care should have a proper distance vision chart. They should know malingering, for what purpose is applying for, is there a secondary gain also, and as rightly pointed out, a visual field is obviously not available, so probably they will refer to, some higher center to get visual field check before giving any certificate to patients.
Maybe there should be policy issues if there's such a big difference in percentage also, because now they're not scared of giving 40%. And if they are pointed out, and if there's a policy change at the government that the actual percentage is 0 and they're giving 40 and some action is taken, maybe even that might help. I'm not sure about this. Thank you so much.
Thank you. The last presenter is Dr. Sonali Prasad.
A very good morning, everyone. First of all, thank you, AIOS, for giving me this opportunity. I'm going to talk about epidemic keratoconjunctivitis among the healthcare workers, the knowledge, attitude, and practice patterns in India. So as we all know, epidemic keratoconjunctivitis is caused by adenoviral with serotype 8, 9, and 37, and the transmission is mostly through fingers or objects or swimming pool. So recently we saw there was a sudden outbreak of pink eye in the general population, and due to its indistinctness, different sources of information and suggestions were developed to guide and prevent the spread of the disease. But to our surprise, despite the knowledge, awareness, proper precautions, the disease also spread among the healthcare workers. So we conducted a pan-India cross-sectional survey to understand their knowledge and perception. So this was a Google form constructed with the help of different peoples all around India, and we concentrated on the demographic details, their experience with viral keratoconjunctivitis, their knowledge, attitude, and practice, and we did a pilot study in 10 subjects, and the validation certificate was taken by the statistician. We took help from social scientists, epidemiologists, and medical doctors to find a study that was suitable, applicable, relevant, and also accurate. So after this online cross-sectional survey that we created, we translated into 2 languages and disseminated it through the help of social media and conducted the survey for 2 months. And we got around 1,092 respondents. We also developed a scoring and analysis system for this. All the responses, the data was, the responses from the Google spreadsheet was converted to Microsoft Excel. And scoring, we did +1 for each correct answers of the multiple choice, and total score of 40 was taken. The cutoff for every knowledge, attitude, and practice was taken as more than the median value. So if the knowledge was more than 18 out of 24 score, it was graded as high knowledge, and for attitude 4 out of 6, it was more than that, then positive, and for practice it was 7 out of 10 was good. So the demographic details, we could see the male and the female were just similar. The doctors were maximum in our group, with nurses being 21, mostly from the private sector, and the postgraduates and undergraduates were the maximum in number. In the geographical distribution, we can see the central India having the maximum number of respondents, and the extreme peripheries of India could not respond well. Talking about their episodes of conjunctivitis, around 68% had an episode of conjunctivitis, with contact with infected patients in OPD was the most common reason. The redness in eye was the most common symptom that they faced, and the severity was of mild grade. The associate symptoms were seen at around 42% showed about fever, and 19% showed preauricular rhinitis was seen in 7%. Most of the respondents were treated with artificial teardrops with antibiotics, and the others were treated with steroids. Their experience was different, and around 40% showed that they had no sequelae of the recovery. Talking about knowledge, we assessed them in 10 questions. I'm not going to go into detail of the question, but when we analyzed, we had around 1,092 respondents, and 841 had a score of more than 18, giving us a score of 77% of good knowledge. Coming about attitude, again, 78.5% had a good positive attitude. The practice patterns concentrated, and 748 respondents scored more than 7 out of 10, giving us a score of 72% having a good practice. So in conclusion, 68% of the the respondents that we had were healthcare workers working in private sectors. 72% had contact with the infected person in OPD. The most common symptom they had were redness, followed by pain, itching, watering, then discharge. The grading of the severity was 1 to 2, and 54% had artificial teardrops with antibiotics as a treatment. So we concluded that the overall CAP analysis of the Pan-India survey was 72% had a good knowledge about the disease, with 78 had a positive attitude, and 72 had a good practice. Thank you so much.
Thank you.
Sir, actually, the methodology is we've constructed this Google Docs, and then we asked the statistician, and we did a validation of the questionnaire had 12 in the knowledge, attitude, and we had divided it accordingly, according to the, and then the statistician's validation we got a certificate from her by doing a pilot study. After the corrections and everything that we got, we distributed it up to Pan-India with the help of social media. And after that, we analyzed the scoring system was based on a scoring system given by during a COVID paper that was in the literature. So we followed their scoring program in our study, sir.
Thank you. This concludes the session.
Thank you,
so we still have, I think, 5 minutes left. So all presenter and can come for group photograph, please.